You know that sound. It's one of the most recognizable and, let's be honest, one of the most concerning sounds we hear in medicine. But have you ever stopped to think about what it's really telling you on a fundamental level? So, you hear that high-pitched whistle coming from a patient. What's the first thing that pops into your head? For most of us, our brain probably jumps straight to asthma, right? Or maybe COPD. And look, you're not wrong, but that is not the whole story. Not even close. Today, we're going to break that sound down to its absolute core message. All right, so first things first, let's get on the same page. What is wheezing, really? So, the textbook definition calls it a musical, high-pitched, continuous breath sound. Now, those keywords are really important. Musical, high-pitched, continuous. This isn't a crackle, it's not raunchy. It's literally the sound of air being forced through a narrowed tube, kind of like a flute or a whistle. And that brings us to the most crucial point. If you strip away all the complex medical jargon for just a second, a wheeze means one incredibly simple thing. Air is squeezing through a tight space. That's it. That is the fundamental message your patient's body is sending you. Okay, so keeping that tight space idea in mind, how does it connect to the diagnoses we all know and think of first? Well, let's start with the usual suspects. Well, with asthma, you've basically got a triple threat making that space tight. You've got bronchospasm clamping down on the airways, you've got inflammation swelling up the tissues, and then you have mucus plugging everything up. And for our COPD and emphysema patients, it's a similar story. Airways collapse and get blocked with mucus. You see, different mechanisms, but the exact same result, a narrowed passage in that classic wheezing sound. Okay, but here's where things get really interesting. What happens when that tight space isn't caused by asthma or COPD? This right here is where a sharp clinician really shines, by thinking beyond the obvious. Because here's the absolute core of it, the main takeaway, if you will. Wheezing doesn't always mean asthma. It's a symptom, not a diagnosis. It's just a clue, a big, loud musical clue that something is creating that tight space. I mean, just think about it for a second. Anaphylaxis? That's just severe swelling creating a critically tight space in the airway. What about CHF? You get fluid backing up into the lungs, squeezing the airways. They even call it cardiac asthma for a reason. A little kid with bronchiolitis, or heaven forbid a peanut stuck in their bronchus. That's inflammation or a physical blockage creating, you guessed it, a tight space. Now this brings us to the most important, and maybe the most terrifying concept of all. I'm talking about the silent chest paradox. I want you to really, truly think about this. You've got a patient in severe respiratory distress. They've been wheezing like crazy, and then, suddenly, things change. What could possibly be more concerning than that loud, high-pitched wheeze?
It's when the wheezing stops. That's right. The most terrifying sound in a severe asthma attack is no sound at all.
This right here is the silent chest. And it all comes back to our core principle. Wheezing is the sound of air squeezing through a tight space. A silent chest means that the airway is so obstructed, so completely slammed shut, that there isn't enough air moving to even make a sound. This patient is about to stop breathing. It is a life-threatening emergency. So how do we boil all this down into something practical, something you can take with you on your next call, your next shift? It really comes down to this simple idea. If you hear wheezing, what does it tell you? It tells you the airway is narrow. It's a problem for sure, but air is still moving. But when you hear silence, where a wheeze should be, that tells you the airway is effectively closed. One is a major problem, the other is an absolute catastrophe. So, I'll leave you with this to think about. The next time you hear that wheezing sound, or maybe more importantly, when you don't, what are you going to be thinking about? You're not just listening for a sound anymore. You're assessing the degree of obstruction. You're asking yourself that critical question. Is this airway narrow or is it dangerously silent?